This recorded lecture will be going over chapters 9, 10, 12, 13, and 14. The postpartum period, or puerperium, is the 6 weeks following childbirth. Postpartum care should expand to beyond 6 weeks in women who may plan additional pregnancies. If possible, when discussing sensitive information, the interpreter should not be a family member who may interpret selectively. Some cultures adhere to the hot and cold theory of diet after childbirth. Involution refers to changes that the reproductive organs, particularly the uterus, undergo after birth to return them to their pre-pregnancy size and condition. The uterus undergoes a rapid reduction in size and weight after birth. The uterine lining is shed when the placenta detaches. The uterine fundus descends at a predictable rate as the muscle cells contract to control bleeding at the placental insertion site and as the size of each muscle cell decreases. By 10 days postpartum, it should no longer be palpable. Intermittent uterine contractions can cause after pains that are similar to menstrual cramps. The discomfort is self-limiting and decreases rapidly within 48 hours after postpartum. Mild analgesics can be prescribed. Vaginal discharge after delivery, called lochia, is composed of endometrial tissue, blood, and lymph. Lochia gradually changes characteristics during the early postpartum period. Lochia has a characteristic fleshy or menstrual odor. It should not have a foul odor. The woman's fundus should be checked for firmness because an uncontracted uterus will allow blood to flow freely from vessels at the placenta insertion site. If a mother has excessive discharge of lochia, a clean pad should be applied and checked within 15 minutes. The flow of lochia is briefly heavier when the mother ambulates because lochia pooled in the vagina is discharged when she assumes an upright position. Large clots should not be present. The absence of lochia is not normal and may be associated with blood clots retained within the uterus or with infection. The fundus should be assessed at routine intervals for firmness, location, and position in relation to the midline. A poorly contracted, soft, or boggy uterus should be massaged until firm to prevent hemorrhage. It is essential not to push down on an uncontracted uterus to avoid inverting it. Catheterization may be necessary if she cannot void. After pains persisting more than 48 hours after birth should be reported. The cervix regains its muscle tone but never closes as tightly as during the pre-pregnant state. The rugae or vaginal folds will disappear and the walls of the vagina become smooth and spacious. The rugae will reappear 3 weeks postpartum. It is important for the nurse to teach the woman that it's considered safe to resume sexual intercourse when bleeding has stopped and the perineum has healed. Instructing the woman to perform Kegel exercises correctly helps her strengthen muscles involved in urination, bowel function, and vaginal sensations during intercourse. The perineum is often edematous, tender, and bruised. The perineum should be assessed for normal healing and signs of complications. Comfort and hygienic measures are the focus of nursing care and patient teaching. The cold pack should be covered with a paper cover or washcloth to prevent tissue damage. After 24 hours, heat in the form of a chemical warm pack, a bidet, or sitz bath will increase circulation and promote healing. The woman is taught to do perineal care after each voiding or bowel movement to cleanse the area without trauma. Topical and systemic medications may be used to relieve perineal pain. Commonly prescribed medications include hydrocortisone and pramoxine and benzocaine. An air ring or donut will take pressure off the perineal area when sitting. Menstrual cycles should resume in about 5 weeks after delivery if the woman is not breastfeeding, or possibly 8 weeks after delivery if the woman is breastfeeding without formula supplementation. Discussion and teaching concerning contraception should be initiated before discharge because the mother may not return to her healthcare provider before 6 weeks postpartum, and she may resume sexual activity before that appointment, which can result in an unplanned pregnancy. Combined oral or transdermal estrogen-progesterone contraceptives can be started 2 to 3 weeks after delivery by women who are not breastfeeding because estrogen suppresses lactation. For breastfeeding women, a low-dose progestin-only contraceptive can be started 4 weeks postpartum. The ideal pregnancy spacing should be approximately 2 years apart. Breast engorgement may occur in both nursing and non-nursing mothers. The engorged breast is hard, erect, and very uncomfortable. The breasts of the non-nursing mother return to their normal size in 1 to 2 weeks. At each assessment, the nurse should check the woman's breast for consistency, size, shape, and symmetry. The nipples are inspected for redness and cracking, which makes breastfeeding more painful and offers a port of entry for microorganisms. Both nursing and non-nursing mothers should wear a bra to support the heavier breasts. The non-nursing mother should avoid stimulating her nipples, which stimulates lactation. The nipples should be washed with plain water to avoid the drying effects of soap, which can lead to cracking. Because a 50% increase in blood volume during pregnancy, the woman can tolerate normal blood loss at delivery, including 500 milliliters in a vaginal birth and 1,000 milliliters in cesarean birth. After the initial post-birth excitement wanes, the pulse rate may be as slow as 50 to 60 beats per minute for about 48 hours after birth. To reestablish normal fluid balance, the body will rid itself of excess fluid in the following 2 ways: diuresis and diaphoresis. Blood clotting factors are higher during pregnancy and for 4 to 6 weeks of the perineum, yet the woman's ability to lyse clots is not increased. Dyspnea and tachypnea are hallmark signs of a pulmonary embolus and that necessary immediate medical intervention. Fluid that shifts into the bloodstream dilutes the blood cells, which lowers the hematocrit. The white blood cell count can rise as high as 12,000 to 20,000 millimeters cubed, a level that would ordinarily suggest infection. The increase is in response to inflammation, pain, and stress, and it protects the mother from infection as her tissues heal. Many mothers experience tremors that resemble shivering or chills immediately after birth. These tremors or chills stop spontaneously within 20 minutes. Chills accompanied by a fever after the first 24 hours will suggest infection and should be reported. After childbirth, resistance to blood flow in the vessels of the pelvis drops. As a result, the woman's blood pressure falls when she sits or stands, and she may feel dizzy or lightheaded or may even faint. The pulse rate will help to interpret temperature and blood pressure values. A high pulse rate will often indicate infection or hypovolemia. The nurse checks for the presence of edema in the lower extremities, hands, and face. The woman's legs should be checked for evidence of thrombosis at each assessment. Early and regular ambulation will reduce venous stasis that promotes blood clots. It is a priority nursing responsibility to offer assistance with bedside sitting, toileting, and ambulation following delivery, especially for women who have had an epidural analgesia or cesarean births. Kidney function returns to normal within a month after birth. The nurse should regularly assess the woman's bladder for distension. The first 2 or 3 voidings after birth or after catheter removal are measured. Some discomfort with early urination is expected due to edema and trauma in the area. The GI system resumes normal activity shortly after birth when progesterone decreases. The nurse should expect to provide food and water to a new mother often. Constipation can occur during the postpartum period as a result of several factors. Medications, abdominal muscles are stretched, hemorrhoids or soreness, and slight dehydration. The mother is encouraged to drink lots of fluid, add fiber to the diet, and ambulate. A stool softener like Docusate Calcium or Docusate Sodium can be ordered. Hyperpigmentation of the skin disappears as hormone levels decrease. Striae will not disappear, but will fade from a reddish purple to silver. The abdominal wall has been greatly stretched during pregnancy and may now have a doughy appearance. They should be reassured that time and exercise can tighten their lax muscles. Also, some women have diastasis recti. This is where the longitudinal abdominal muscles that extend from the chest to the symphysis pubis are separated. A woman can usually begin light exercises as soon as the first day after vaginal birth. The Rh-negative mother should receive a dose of RHO immune globulin or RhoGAM within 72 hours after giving birth to an Rh-positive newborn. RhoGAM is given to the mother, not to the newborn. The mother who is not immune is given the rubella vaccine in the immediate postpartum period. The woman should not get pregnant for the next month following vaccination. Women vaccinated during the postpartum period can breastfeed without adverse effects to the newborn. Some variations of normal postpartum care will be needed for the woman who experienced a cesarean birth. The nurse should check and document the descent and firmness of the fundus as on any new mother. It descends at a similar rate. The quantity of lochia immediately after cesarean birth is generally less because surgical sponges have removed the contents of the uterus. When a dressing is present, it should be checked for drainage, as with any surgical patient. When the dressing is removed, the incision is assessed for signs of infection. The RITA acronym is a good way to remember key items to check with an incision. The woman can shower as soon as she can ambulate reliably. The dressing is changed after the woman finishes her shower. An indwelling urinary catheter is generally removed within 24 hours after delivery. The nurse should observe for and teach the woman to observe for signs of urinary tract infection. Lung sound should be auscultated each shift for clarity. When she is confined to bed, the woman should take deep breaths and turn from side to side every 2 hours. To reduce incisional pain from coughing or other movement, the nurse can have the woman hold a small pillow or folded blanket firmly against her incision. The woman should begin ambulating as early as possible to mobilize lung secretions. The woman who has undergone a cesarean birth has a greater risk for thrombophlebitis. She should do simple leg exercises, such as alternately flexing and extending her feet or moving her legs from a flex to an extended position when turning. Pain control is essential to reduce the woman's distress and facilitate movement that can prevent several complications. Some women receive epidural narcotics for long-lasting pain relief. These drugs can cause respiratory depression many hours after they're administered, sometimes up to 24 hours. Some women will have a PCA pump to provide them with analgesia. Most women will change to an oral analgesic on the day after surgery. The breastfeeding mother should be reassured that timing the administration of the analgesia immediately after breastfeeding minimizes the passage of the drug via breast milk to the newborn. Fluctuating hormones in pregnancy and the puerperium have an effect on mood, causing early elation at delivery that can be followed by a mild depression, with tearfulness, irritability, and fatigue peaking on the 5th day postpartum. Rubin has described 3 phases of postpartum change that has served as a framework for nursing care for more than 50 years. You can see these on Table 9.2 on page 221. The symptoms of the postpartum blues are often self-limiting. Postpartum depression is a persistent mood of unhappiness. The nurse should explain that persistent depression is not expected and should be reported to her healthcare provider. Many women do not have the opportunity to rest and adapt in the postpartum phase. The nurse should assess the level of maternal fatigue and initiate appropriate relief measures, like taking on the care of a newborn for a few hours or scheduling events that allow for periods of rest. The demands of parenthood affect communication between the partners, and there is little doubt that children distract from the relationship at times. Fatigue can trigger irritability. Ideally, preparing parents for their lifestyle changes that occur with a new child should begin before conception. Encouraging parents to share their concerns and worries with one another and keep communication lines open are foremost. New fathers typically display intense interest in their new child. According to Goodman, new fathers often experience 4 phases of adjustment to fatherhood, characterized by the following: having expectations and personal intentions, confronting reality and overcoming frustrations, creating one's own personal father role, and reaping the rewards of fatherhood. The nurse must be tactful and supportive of a new father who is trying to assume his new role. The siblings of a The influence of a new child's birth on siblings will depend on their age and developmental level. The grandparents' involvement with a new child is often dictated by how near they live to the younger family. If parents and grandparents agree on the grandparent's role, little conflict is likely. Nurses occasionally care for grieving parents. With most of these parents, the nurse should simply listen to them and support them. Most parents eventually come to accept their unique newborn and his or her characteristics. The nurse should accept and encourage expressions of grief to allow them to move forward and accept the newborn they have. The woman who has experienced the loss of a newborn may experience regret, remorse, and sorrow. The birth of a new child could awaken grief that parents thought that had resolved. If the condition of a newborn is poor, the parents may wish to have a baptism performed. If the newborn dies, is stillborn, or has a birth defect, the parents' reactions depend on whether the event was expected. The nurse may encounter grieving families at any point in their grieving process and in many settings. If a newborn dies or is stillborn, newborn units have a protocol to help parents accept and resolve the event in their minds. The newborn should be wrapped in a blanket, and the parents should be allowed to unwrap the newborn when and if they want to do so. The nurse should listen to the parents' responses to determine the level of support needed, answer questions, and understand the grief behaviors individual to the family or culture. Parents should be provided with private time with the newborn if possible, and given mementos to take home. The family care plan is similar to the traditional nursing care plan, except that the patient is the entire family rather than the woman in the hospital. The data required in a family care plan is listed in Nursing Care Plan 9.2. Follow-up appointments with the healthcare provider for both the mother and the baby should be given to them before they leave the hospital. If the newborn has adequate cardiorespiratory and heating regulating functions, he or she will usually remain undisturbed while the parents and newborn become acquainted. The nurse can usually assess temperature, heart rate, and respirations while the parents continue to hold their newborn. The temperature of the newborn should be 36 to 36.5 degrees Celsius of the skin, or 36.5 to 37 degrees Celsius axillary. Hypothermia can cause other problems, such as hypoglycemia, respiratory distress. Newborns will lose heat quickly after birth because amniotic fluid evaporates from their body. Drafts will move heat away and they may contact cold surfaces. You can read more about this in Table 9.3 on page 225. The first bath should be delayed until the body temperature is stabilized at 36.5 to 37 degrees Celsius. Newborns may not urinate for as long as 24 hours, and occasionally a newborn may not void for 48 hours. 70% of term newborns will pass meconium in the first 12 hours. Meconium should be passed before discharge for assurance of a patent GI tract. In the maternal newborn setting, security begins with identification bands that the nurse matches every time the newborn is reunited with the parent. Wristbands with pre-printed numbers are placed on the mother, the newborn, often the father or another support person in the birthing room, as the primary means of identifying the newborn. The nurse should check to be sure that all numbers in the set are identical. Each time the newborn returns to the mother after a separation, the nurse must check the pre-printed band numbers to see if they match. The mother is taught to keep the newborn away from the door to the room, and the mother should not leave her newborn alone in the room for any reason. Vital signs will be measured at 15 to 30-minute intervals at first, then hourly and every 4 to 8 hours after the newborn is stable. The newborn is weighed in the birthing room or when admitted to the nursery. The nurse's hand should not touch the newborn, but should be kept just above him or her to prevent falls. The kilogram weight will be reviewed at every shift handoff. 3 typical measurements include length, head circumference, and chest circumference. A disposable tape measure will be used. Delayed cord clamping in the newborn for 30 to 60 seconds after birth will provide a better newborn outcome due to increased iron stores provided to the newborn. The cord will be assessed for the number and type of blood vessels soon after it is cut. Umbilical cord care is aimed at preventing infection. The diaper should be fastened low to allow air circulation to the cord. Bleeding from the cord during the first few hours usually indicates that the cord clamp has become loose. Until newborns begin regular feedings, they must use the glucose stored in their bodies. A blood glucose lower than 45 milligrams per deciliter 2 hours after birth is considered to be hypoglycemia. Some newborns at risk for low blood glucose after birth include preterm and post-term newborns, small for gestational age and large for gestational age newborns, newborns of diabetic mothers, and any newborn who is stressed because of hypoxia. Signs of hypoglycemia in the newborn include the following: jitteriness, poor muscle tone, sweating, respiratory difficulty, low temperature, poor suck, high-pitched cry, lethargy, and seizures. A panel of more than 31 tests is undertaken to screen for abnormalities that are known to cause physical or mental disability. Initial skin care after the newborn's condition is stable involves washing off the blood and amniotic fluid that may be present on the newborn's skin. Bonding refers to a strong emotional tie that forms soon after birth between the partners, the parents, and the newborn. Attachment is an affectionate tie that occurs through time as the newborn and caregivers interact. Both partners should view, hold, and most importantly, touch the newborn as soon as possible after birth. Difficulty in bonding, rejection, or indifference in one or both parents should be recorded and a referral to social services be considered. The amount of physical contact, stimulation, eye-to-eye contact, and time spent interacting with the newborn are significant. Parents must learn what their newborn's communication cues mean. The nurse should observe for parent-newborn interactions that dictate a need for additional interventions. Some of these include indifference to the newborn's signals of hunger or discomfort, failure to identify their newborn's communication, avoidance of eye contact with the newborn, or discussing the newborn in negative terms. A newborn stays in the mother's room for most of the time unless either mother or newborn has a problem that necessitates separation. Feeding and elimination patterns are assessed by discussing them with the mother and observing at diaper changes. If the newborn is breastfed, the nurse should discuss with the mother how well the newborn is nursing, the frequency and duration of the nursing sessions, and any difficulty she is having. The newborn's skin should be observed for jaundice at each assessment. A cap is used because the newborn's head is the largest body surface area and can be a source of significant heat loss. Parent teaching of newborn care includes the following: maintenance of an open airway by positioning and use of the bulb syringe, temperature maintenance and assessment after discharge, expected increase in the number of voidings, changes in stools, feeding, signs of illness to report, and follow-up appointments for well baby care. The first feeding should be observed carefully because anomalies that cause choking could be present. Breastfeeding has many advantages for the newborn. Breast milk contains the full range of nutrients that the newborn needs and in the right proportions. Breast milk is easily digested by the newborn's maturing digestive system. Breast milk does not cause newborn allergies. Breastfeeding provides natural immunity. Breast milk promotes elimination of meconium. Suckling at the breast promotes mouth development. Breastfeeding is convenient and economical. Breastfeeding eliminates the risks of a contaminated water supply or improper dilution. Newborn suckling promotes a return of the uterus to its pre-pregnant state. Breastfeeding may play a significant role in improving brain development of the newborn. Breast milk production uses maternal fat stores, which facilitates maternal weight loss. Breastfeeding enhances a close mother-child relationship, and breastfeeding can reduce the occurrence of childhood respiratory disorders and diabetes in the infant. The only infections that are absolute contraindications to breastfeeding are those caused by HIV and the human T-cell lymphotrophic viruses, all of which could be transmitted to the newborn via breast milk. Newborn suckling at the breast stimulates the release of oxytocin so that milk is delivered to the nipple, where it is then ingested by the newborn. Prolactin secretion increases as milk is removed from the breast, thus stimulating further milk production. Milk production will change after birth in the following 3 phases: colostrum, transitional milk, and mature milk. Colostrum is secreted by the breast late pregnancy and for the first few days after birth. It is yellowish fluid rich in protective antibodies. Newborns are more likely to be breastfed and to breastfeed longer if they had skin-to-skin contact and breastfeeding initiated in the delivery room. Breastfeeding should not be delayed beyond 6 hours after delivery. Table 9.4 on page 233 reviews some techniques that the nurse can teach a new mother who wants to breastfeed. The mother may sit in bed or in a chair and hold the newborn in a cradle hold with the head in her antecubital area. The mother may prefer a football hold, supporting the newborn's head with her hand while the newborn's body rests on pillows alongside her hip. The mother may prefer to lie on her side with the newborn's body parallel to hers. Regardless of the position selected for breastfeeding, the newborn's body should be in a chest-to-chest position with the mother, with the head and neck in alignment. The mother is taught to wash her hands before each breastfeeding session. Breastfeeding should begin with the opposite breast from the one that began in the previous feeding session. The mother is taught to allow the newborn to become alert and hungry, but not frantic. Suckling is the term that specifically relates to giving or taking nourishment at the breast. Noisy suckling or smacking sounds or dimpling of the cheeks usually indicates improper mouth position. Fluttering sucking means motions indicate non-nutritive suckling. When the newborn must be repositioned or changed to the other breast, the mother should quickly break the suction and remove the newborn quickly. Signs that breastfeeding is successful include the following. Breast feels firm before feedings and soft after. Letdown reflex occurs. Newborn nurses at the breast for 10 to 15 minutes per breast 8 to 10 times a day. An audible swallow is heard as the newborn sucks. Newborn demands feeding and appears relaxed after feeding. Newborn has 6 to 8 wet diapers per day, and the newborn passes stool several times per day. Pain, anxiety, and insecurity can inhibit the letdown reflex and are the most common reasons for breastfeeding problems. Breastfed newborns usually nurse every 2 to 3 hours during the early weeks because their stomach capacity is small and because breast milk is easily digested. Mothers should be taught how to recognize signs of early hunger in their newborns, and you can read about these in box 9.2 on page 236. The newborn should nurse at least 15 minutes on the first breast, or longer if still nursing vigorously. The total duration of early feedings should be at least 15 minutes per breast. Exclusively breastfed infants have lower rates of otitis media, respiratory infection, gastroenteritis, UTIs, and thrush, as well as a reduced risk of diabetes mellitus, childhood leukemia, obesity, and necrotizing enterocolitis. Breastfeeding also positively and significantly influences intelligence in the newborn. Some newborns are sleepy and need to be awakened for feedings until a routine of feeding on demand is scheduled. Newborns must be calmed before successful feeding can be attempted. Stiffening and crying after feeding starts can indicate a sore mouth from thrush, gas, cramps, or some illness that requires a healthcare provider's intervention. Successful breastfeeding is based on supply and demand. When lactation is firmly established, usually after the neonatal period, the use of a pacifier to meet non-nutritional sucking needs will not cause nipple confusion. Early, regular, and frequent nursing helps to prevent breast engorgement. Cracks, blisters, redness, and bleeding may occur. Correct positioning of the newborn is the best preventative measure. The mother should not use soap on her breasts. If the newborn cannot nurse, the mother can pump her breast and freeze the milk for tube feedings. When breastfeeding must be temporarily delayed, the mother should be taught how to pump her milk to continue full breastfeeding. The mother should be taught how to assemble, disassemble, and clean the breast pump. Pumping should last approximately 10 minutes on each breast and should be done about every 3 hours. Weaning from the pump should be gradual. Breast milk should be used or stored within 1 hour of pumping to avoid the potential for bacterial contamination. Any plastic material used for infants should be labeled as bisphenol A or BPA free. Milk can be thawed in the refrigerator for 24 hours or by holding the container under running lukewarm water or placing it in a container of lukewarm water, rotating, not shaking, the bottle often. Freezing can destroy some of the antimicrobial factors in the breast milk. Thawed milk should not be stored in the refrigerator for longer than 24 hours. Some foods eaten by the mother may change the taste of the milk or cause the infant to have gas. If the mother suspects that a particular food is causing fussiness or gas in the infant, she can eliminate from her diet for a few days to determine whether the infant has fewer problems. Gradual weaning is preferred to abrupt weaning, which can cause engorgement, lead to mastitis, and be upsetting to the newborn. The nurse can teach mothers the following tips when they want to wean their newborns. Eliminate one feeding at a time. Omit daytime feedings first, starting with the one in which the newborn is least interested. Eliminate the newborn's favorite feeding last. Expect the newborn to need comfort nursing if he or she is tired, ill, or uncomfortable. If the mother must wean abruptly for some reason, breast engorgement is likely to occur. Before the first formula feeding, most hospitals have a policy of offering water to the newborn to assure patency of the GI tract. Aspiration of water involves less risk than the aspiration of formula. Most formulas are a modification of cow's milk. The parent should wash their hands before preparing formula and feeding the infant. Bottles of formula can be prepared one at a time, or a 24-hour supply can be prepared. Ready-to-feed formulas will require no dilution. Like the breastfeeding mother, the formula feeding mother should be encouraged to avoid rigid scheduling. Many mothers prefer to warm the formula somewhat, but this is not necessary. Propping the bottle may cause the infant to aspirate formula and is associated with dental caries and ear infections. Because mothers and infants are discharged quickly after birth, self-care and infant care teaching must often begin before the mother is psychologically ready to learn. Ample written materials for both the new mother and infant should be provided to refresh the memory of parents who may be tired and uncomfortable when the teaching occurs. The nurse teaches the new mother how best to care for herself to reduce her risk of complications. Most healthcare providers will want to see the postpartum woman 2 weeks and 6 weeks after birth. At the 2-week appointment, the healing of the mother's perineum or cesarean incision is assessed. Perineal care should be continued until the flow of lochia stops. Douches and tampons should not be used for sanitary protection until after the 6-week checkup. Coitus should be avoided until the episiotomy is fully healed and lochia flow has stopped. Ovulation, and therefore pregnancy, can occur before the 6-week checkup. It is important to emphasize that breastfeeding is not a reliable contraceptive. When contraceptive medication is indicated, a progestin-only, the mini pill, an IUD, or contraceptive implants will not negatively affect lactation. A well-balanced diet and moderate exercise promote healing and recovery from birth. Breastfeeding mothers should not try to lose weight while nursing. Hemorrhage, infection, and thrombosis are the most common complications. The mother should report the following: a fever higher than 38 degrees Celsius, persistent lochia rubra or lochia that has a foul odor, bright red bleeding, prolonged afterpains, pelvic or abdominal pain, or a constant backache, signs of a UTI, pain, redness, or tenderness of the calf, localized breast tenderness or redness, discharge, pain, redness, or separation of any suture line, and the prolonged or pervasive feeling of depression or being let down, generally not enjoying life. Discharge planning for the newborn begins at birth. Most newborns are checked by a healthcare professional at birth and before discharge. Newborns are usually seen again at 6 to 8 weeks after birth to begin well baby care. The nurse should teach parents the importance of the newborn car safety seat and their correct use. New parents should be given written instructions because they are often overwhelmed at the volume of information provided at such a short time. Postpartum shock related to childbearing includes the following: cardiogenic shock, hypovolemic shock, anaphylactic shock, and septic shock. The inherent danger of obstetric shock is that the body compensation can mask the signs until the condition becomes life-threatening. Postpartum hemorrhage is traditionally defined as a blood loss greater than 500 milliliters after vaginal birth or 1,000 milliliters after cesarean birth, resulting in signs or symptoms of hypovolemia. Early, primary postpartum hemorrhage occurs within 24 hours of birth. Late postpartum hemorrhage occurs after 24 hours and within 6 weeks after birth. The major risk of hemorrhage is hypovolemic shock, which interrupts blood flow to body cells. Hypovolemic shock will occur when the volume of blood is depleted and cannot fill the circulatory system. The body initially responds to a reduction in blood volume with increased heart and respiratory rates. Tachycardia is usually the first sign of inadequate blood volume. Blood flow to non-essential organs gradually stops to make more blood available for vital organs, specifically the heart and brain. As blood loss continues, flow to the brain decreases, resulting in mental changes like anxiety, confusion, restlessness, and lethargy. Medical management of hypovolemic shock resulting from hemorrhage may include any of the following actions: stopping the blood loss, giving IV fluids, giving blood transfusions, giving oxygen, placing an indwelling Foley catheter to assess urine output, and uterine massage and administration of drugs to contract the uterus. Routine postpartum care involves assessing the vital signs every 15 minutes until stable, so that the signs of postpartum hemorrhage are identified as early as possible. Routine frequent assessment of lochia in the 4th stage of labor helps identify early postpartum hemorrhage. In the first hours postpartum, the perineal pad should be weighed to determine the output. 1 gram equals 1 milliliter. Careful explanations to the mother and family are essential, and providing emotional support and maintaining the integrity of the woman's support system are key nursing roles. Early postpartum hemorrhage results from one of 3 causes: uterine atony, lacerations of the reproductive tract, or hematomas in the reproductive tract. Atony describes a lack of muscle tone. If the uterus is atonic, these muscle fibers are flaccid and do not compress the vessels. Uterine atony allows the blood vessels at the placenta site to bleed freely and usually massively. After a full birth, the uterus should easily be felt through the abdominal wall as a firm mass about the size of a grapefruit. Lochia rubia should be dark red, and large clots are not normal. When uterine atony occurs, the woman's uterus is difficult to feel and when found feels boggy. A full bladder interferes with the ability of the uterus to contract, and if not corrected, eventually leads to uterine atony. Lochia is increased and may contain large clots. Collection of blood in the uterus further interferes with the contraction and worsens uterine atony and postpartum hemorrhage. When the uterus is boggy, it should be massaged until firm, but it should not be overly massaged. If the uterus is firmly contracted, it should be left alone. Pressing toward the vagina should expel any clots or blood pooled in the vagina after the uterus is firm. First, the uterus is massaged to firmness, and then the bladder is emptied to keep the uterus firm. A dilute oxytocin IV infusion is the most common drug ordered to control uterine atony. Excessive bleeding can also be managed by providing a uterine tamponade, using an intrauterine balloon, selective arterial embolization, or surgical ligation of the artery. The woman should be NPO until her bleeding is controlled. Lacerations of the perineum, vagina, cervix, or area around the urethra can cause postpartum bleeding. Blood lost in lacerations is usually a brighter red than lochia, and it flows in a continuous trickle. Typically, the uterus is firm. The injury is usually sutured in the delivery or operating room. The woman should be kept on NPO status until further orders are received, because she may need a general anesthetic for repair of the laceration. A hematoma is a collection of blood within the tissues. Hematomas resulting from birth trauma are usually on the vulva or inside the vagina. They may be easily seen as a bulging bluish or purplish mass. Discomfort after childbirth is normally minimal and easily relieved with mild analgesics. The woman does not have unusual amounts of lochia, but she may develop signs of concealed blood loss if the hematoma is large. Small hematomas usually resolve without treatment. Larger ones may require incision and drainage of the clots. An ice pack to the perineum is sufficient for most small perineal hematomas and requires no physician prescription. Signs of concealed blood loss accompanied by maternal complaints of severe pain, perineal or vaginal pressure, or inability to void should be reported. The medication tranexamic acid can be used to inhibit the breakup of clots that form. This supports the developing blood clot that is necessary to control hemorrhage. Late postpartum hemorrhage usually occurs after discharge from the hospital and typically results from the following: either retention of placental fragments or subinvolution of the uterus. Placental fragments are more likely to be retained if the placenta does not separate cleanly from its implantation site after birth, or if there is disruption of the placental scab. Treatment consists of the administration of drugs such as oxytocin, methyllergonovine or prostaglandins to contract the uterus. Firm uterine contraction often expels the retained fragments, and no other treatment is needed. If bleeding continues, cutterage is performed to remove small blood clots and placental fragments. The woman should be instructed to report the following signs of late postpartum hemorrhage to her healthcare provider: persistent bright red bleeding, or the return of red bleeding after it had changed to pinkish or white. Involution is the return of the uterus to its non-pregnant condition after birth. Normally, the uterus descends at a rate of 1 centimeter per day and is no longer palpable by 12 days postpartum. Subinvolution is slower than expected return of the uterus to its non-pregnant condition. Infection and retained fragments of the placenta are the most common causes. Typical signs of subinvolution include the following: a fundal height greater than expected for the amount of time since birth, persistence of lochia rubra, or a slowed progression through the 3 phases, pelvic pain, heaviness, and fatigue. Medical treatment is selected to correct the cause of the subinvolution. It may include the following: methyllergonovine, antibiotics for infection or dilation of the cervix, and cutterage to remove the fragments of placenta from the uterine wall. The mother will almost always have been discharged when subinvolution of the uterus occurs. Women should report fever, persistent pain, persistent red lochia, or foul-smelling vaginal discharge. Nursing care involves assisting with medical therapy and providing analgesics and other comfort measures. Specific nursing care depends on whether the subinvolution results from infection or another cause. The pregnant woman is at an increased risk for venous thrombosis because of the venous stasis that occurs due to compression of the blood vessels by the heavy uterus or by pressure behind the knees when the legs are placed in the stirrup leg supports for episiotomy repair. If the woman has varicose veins or remains on bed rest, her state of hypercoagulability places her at an increased risk for venous thrombus formation. Preventative measures include the use of pneumatic compression devices on the lower extremities or prophylactic heparin for women undergoing cesarean sections or who are on prolonged bed rest. There are 3 types of thromboembolic disorders: superficial venous thrombosis, deep venous thrombosis, and pulmonary embolism. Superficial venous thrombosis is treated with the administration of analgesics, local application of heat, and elevation of the legs to promote venous drainage. Deep venous thrombosis is treated similarly with the addition of subcutaneous or IV anticoagulation drugs like heparin. Dyspnea, coughing, and chest pain suggest a PE and must be reported immediately. Prevention of thrombi is the most important. Pregnant women should not cross their legs because this impedes blood flow. Measures to promote venous flow should be continued during and after birth because levels of clotting factors remain high for several weeks. Anti-embolic stockings can be used if varicose veins are present. The woman who will be undergoing anticoagulant therapy at home should be taught how to give herself the drug and about signs of the excess anticoagulation. Puerperal sepsis is an infection or septicemia after childbirth and is the 4th leading cause of maternal mortality in the United States. Tissue trauma during labor, the open wound of placental insertion site, surgical incisions, cracks in the nipples of the breasts, and the increased pH of the vagina after birth are all risk factors for the postpartum woman. Fever is most likely caused by endometritis, an inflammation of the inner lining of the uterus. The danger of postpartum infection is that a localized infection of the perineum, vagina, or cervix can ascend the reproductive tract and spread to the uterus, fallopian tubes, and peritoneum, causing peritonitis, which is a life-threatening condition. Puerperal fever is defined as a temperature of 38 degrees Celsius or higher after the first 24 hours and for at least 2 days during the first 10 days after birth. The assessment of any C-section wound or episiotomy should be done using the RITA criteria, or hardening of the operative area should be promptly reported and documented. The goals of medical treatment are to limit the spread of infection, to prevent it from reaching the blood and other organs, and eliminate the infection. Nursing care objectives will focus on preventing infection and, if an infection occurs, on facilitating medical treatment. Women should be taught to wash their hands before and after performing self-care that may involve contact with secretions. Nutrition is an essential component of her body's defenses. Mastitis is an infection of the breast. It usually occurs about 2 or 3 weeks after giving birth. Breast engorgement and inadequate emptying of milk are associated with mastitis. Mastitis often involves only one breast. Signs and symptoms of mastitis include the following: redness and heat in the breast, tenderness, edema and a heaviness in the breast, and purulent drainage. The woman usually has fever, chills, and other systemic signs and symptoms. If not treated, the infected area becomes encapsulated and an abscess forms. Antibiotics and the continued removal of milk from the breast are the primary treatments for mastitis. Mild analgesics make the woman more comfortable. The mother can usually continue to breastfeed. She should not wean her infant when she has mastitis, because weaning will lead to engorgement and the stasis of milk, worsening the mastitis. The nursing mother should be taught proper breastfeeding techniques to reduce the risk for mastitis. Nursing care for mastitis centers on relieving pain and maintaining lactation. On page 256 within the blue patient teaching box, you can read some more about mastitis. Both breasts should be emptied regularly to reduce milk stasis, which increases the risk for abscess formation. A mood is a pervasive and sustained emotion that can color one's view of life. Postpartum blues or baby blues are common after birth. A psychosis involves the serious impairment of one's conception of reality. Postpartum blues, also known as an adjustment reaction, occur in about 75% of women, appearing on day 5 and disappearing by day 10. There are 3 types of postpartum depression: adjustment disorder, postpartum mood disorders, postpartum depression. Postpartum depression is a depressive illness that is usually manifested within 2 to 4 weeks after delivery. The nurse can promote the behaviors that improve mental health. Risk factors for postpartum depression include inadequate social support, a poor relationship with the partner, life and child care stress, a low self-esteem, and an unplanned pregnancy. Signs and symptoms may include the following: a lack of enjoyment in life, disinterest in others, intense feelings of inadequacy, unworthiness, guilt, and an inability to cope, loss of mental concentration, disturbed sleep or appetite, and constant feelings of fatigue or feeling of ill health. A combination of psychotherapy and antidepressants is often the course of therapy, either in an outpatient or inpatient setting. The nurse provides support and observation of behavior and is alert to the possibility of self-harm by the woman. Referral for follow-up to an available community mental health support service and facilities is a nursing responsibility to assure ongoing care and support. Women experiencing a postpartum psychosis have an impaired sense of reality. A woman may have any psychiatric disorder, but these 2 are most commonly encountered: bipolar disorder and major depression. Postpartum psychosis can be fatal for both the mother and the infant. In some cases, social workers within the community may refer the woman for counseling. In other cases, an inpatient psychiatric treatment center is the appropriate environment for treatment. Homeless women often have difficulty accessing care, receive care from different healthcare providers at different sites, and have incomplete medical records. Before a mother is discharged with her newborn infant, it is essential to determine that she has a place to go and has a way of accessing help for herself or the newborn. The Neonatal Behavioral Assessment Scale has increased the understanding of the newborn's capabilities. When the umbilical cord is clamped and cut, the lungs take on the function of breathing oxygen and removing carbon dioxide. The healthcare provider assists the first respiration by removing mucus from the passages to the lungs. The most critical period for the newborn is the first hour of life, when the drastic change from life within the uterus to life outside the uterus takes place. Gently clearing mucus with a bulb syringe may be indicated. Parents are taught how to use the bulb syringe and are instructed to keep one next to the newborn during the early weeks of life. The nurse can assist newborns to maintain a patent airway by positioning them on their back or side and while dressing them in clothing that maintains warmth while allowing expansion of the lungs. The nurse should record vital signs and should suction mucus as needed, first from the mouth and throat and then from the nose. The APGAR score is a standardized method of evaluating the newborn's condition immediately after delivery. 5 objective signs are measured: heart rate, respiration, muscle tone, reflexes, and color. The score is obtained 1 minute after birth and then again after 5 minutes. Respiratory distress may be evidenced by the rate and character of respirations, color, and general behavior. The newborn has approximately 300 milliliters of circulatory blood volume. Murmurs may be functional or organic. Functional murmurs result from blood passing through normal valves. Organic murmurs are caused by blood passing through abnormal openings. Body temperature falls immediately after birth, but within a few hours it climbs slowly to the range of 36.6 to 37.2 degrees Celsius, aided by the metabolism of brown adipose tissue. This process is known as non-shivering thermogenesis. The newborn's hands and feet are not used as guides to determine warmth because the infant's extremities are cooler than the rest of the body. Acrocyanosis is also evident due to sluggish peripheral circulation. Because the sweat glands do not function effectively during the neonatal period, the newborn infant is at risk for developing an elevated temperature if overdressed or placed in an overheated environment. The newborn's apical pulse rate and respiration should be counted before the temperature is taken because the infant is apt to cry when disturbed. The newborn's pulse is irregular and rapid and varies from 110 to 160 beats per minute. Blood pressure is low and may vary with the size of the cuff used. The average blood pressure at birth is 80/46 millimeters of mercury. The respirations are approximately 30 to 60 breaths per minute. Daily routine temperatures are taken by temporal artery thermometers or by axilla. The nurse should always report a pulse rate greater than 160 beats per minute or less than 110 beats per minute. Respirations greater than 60 breaths per minute or less than 30 breaths per minute. Noisy respirations, nasal flaring or chest retraction, or a temperature elevated above 37.7 degrees or below 36.2 degrees Celsius. The skeleton is flexible and the joints are elastic to accommodate the passage through the birth canal. If the infant lies constantly in one position, the bones of the head can become flattened. The movements of the newborn are random and uncoordinated. The length of the average newborn is 46 to 56 centimeters. The weight varies from 2,722 to 4,082 grams, or about 6 to 9 pounds. In the first 3 to 4 days after birth, the infant loses about 5 to 10% of the birth weight. The kidneys function at birth but are not fully developed. The nurse must keep an accurate record of frequency of urination, and the newborn should have about 6 wet diapers per day. The testes of the male descend into the scrotum before birth. The location of the urethral opening should be at the tip of the penis in newborn boys. The female genitalia may be slightly swollen. A thin, white, or blood-tinged mucus may be discharged from the vagina. The nurse should cleanse the vulva from the urethra to the anus, using a clean cotton ball or different sections of washcloth for each stroke to prevent fecal matter from infecting the urinary tract. On page 296 in the blue patient teaching box, you can read about home care of the penis. Tissue turgor refers to hydration or dehydration of the skin. To test tissue turgor, the nurse should gently grasp and release the skin. White pinpoint pimples caused by the obstruction of sebaceous glands could be seen on the nose and chin. Mongolian spots are bluish discolorations of the skin. These are common in infants of African American, Native American, or Mediterranean descent. They are usually found over the sacral and gluteal areas, and they disappear spontaneously during the early years of life. Central body areas should not be cyanotic in normal newborns. Pallor is not normal and should be reported because it may indicate neonatal anemia or another more serious condition. Desquamation or peeling of the skin occurs during the early weeks of life. Physiological jaundice, also known as icterus neonatorum, is characterized by a yellow tinge of the skin. It is caused by the rapid destruction of excess red blood cells, which the infant does not need now because he or she is in an atmosphere that contains more oxygen that was available during prenatal life. Two commonly used methods to assess jaundice are the icterometer and the transcutaneous bilirubin measurement. You can read some more about the interactive bath and the skill of bathing the newborn on page 301 within Skill 12.5. The normal functions of the GI tract should begin after birth. Meconium is the first stool. It is a dark greenish black, thick and sticky, and it is past 8 to 24 hours after birth. Stools will gradually change during the first week. Newborns will differ in regularity. The nurse explains to parents that straining in the newborn period results from undeveloped abdominal musculature. This is normal and no treatment is needed. Even if 5 to 6 days pass without a stool, it is not considered constipation if the stool passed is large in volume and soft or pasty in character. Crying, restlessness, fist sucking, and an evident rooting reflex give evidence to an infant's hunger. The capacity of the infant's stomach is about 90 milliliters. Emptying time is 2 to 3 hours, and peristalsis is rapid. Feeding the newborn will often stimulate the gastrocolic reflex, resulting in the infant passing a stool. Infections that are relatively harmless to an adult may be fatal to the newborn. An open wound could be a portal of entry or infection. Measures to prevent infections in the newborn nursery include using standard precautions, hand washing, cleansing and replacement of equipment, and the proper disposal of soiled diapers and linens. Hand washing is the most reliable precaution available. Discharge teaching ideally begins with the admission of the woman to the hospital or birthing center. Areas of teaching should include the following: basic care of the infant, safety measures, support groups, return appointments for well baby care, the proper use of car safety seats, and any signs and symptoms of problems and whom to contact. It helps if the newborn has a separate room or separate area within a room. A crib with a firm mattress is a suitable place for the infant to sleep. Crib slats should adhere to safety standards. For safety reasons, a pillow should not be placed in the crib of the newborn. A separate linen hamper for the infant's clothes and a closed receptacle for soiled diapers are also necessary. Clothing must be soft, washable, of the proper size, and easy to put on and take off. Parents are instructed to launder new clothing and sheets before using them to prevent skin irritation. Diapers that have been improperly washed and rinsed may aggravate rashes. If a rash is present, the buttocks should be kept exposed to air as often as possible. Diapers should be changed as soon as they are wet. The home health nurse is a key member of the interdisciplinary healthcare team who can help with the after-discharge needs of the family. Any newborn whose life or quality of existence is threatened or considered to be in a high-risk category and requires close supervision by professionals in a NICU. Preterm infants also have a higher percentage of birth defects. In the past, a newborn was classified solely by birth weight. The emphasis is now on gestational age or level of maturation. Gestational age refers to the actual time from conception to birth that the fetus remains in the uterus. For the preterm infant, this is less than 37 weeks. An early term infant is born between 37 weeks and 38 weeks and 6 days. A low birth weight infant weighs 5.8 pounds or less. The Ballard score is an estimated gestational age based on the mother's last normal menstrual period. Ultrasound evaluations can also be used as methods to evaluate the gestational age of the newborn infant. The level of maturation refers to how well developed the infant is at birth and the ability of the organs to function outside of the uterus. Prematurity may be caused by multiple births, illness of the mother, or the hazards of pregnancy itself, such as gestational hypertension, placental abnormalities that may result in premature rupture of the membranes, placenta previa, and premature separation of the placenta. Multidisciplinary care is vital, particularly because current studies indicate a correlation between high-risk births and child abuse and neglect. The skin is transparent and loose in the preterm newborn. There is a lack of subcutaneous fat, and fine hair covers the foreheads, shoulders, and arms. The extremities appear short. Important structural changes occur in the fetal lungs during the second half of pregnancy. The alveoli or air sacs enlarge, which brings them closer to the capillaries in the lungs. The failure of this phenomenon to occur may lead to deaths attributed to previability. The muscles that move the chest are not fully developed. The abdomen is distended, creating pressure on the diaphragm. The stimulation of the respiratory center in the brain is immature, and the gag and cough reflexes are weak due to immature nerve supply. Respiratory distress syndrome, also known as hyaline membrane disease, is also known as respiratory distress syndrome type 1. An estimated 30% of all neonatal deaths will result from RDS or its complications. The symptoms of RDS are apparent after delivery, but they may not manifest for several hours. Respirations increase to 60 breaths per minute or more. Rapid respirations are accompanied by grunt-like sounds, nasal flaring, cyanosis, and intercostal and sternal retractions. Surfactant begins to appear in the fetal alveoli at approximately 24 weeks of gestation, and it is at a level to enable the infant to breathe adequately at birth by 34 weeks gestation. If insufficient amounts of surfactant are detected through amniocentesis, it is possible to increase its production by giving the mother injections of corticosteroids, like betamethasone. Vital signs are monitored closely, and arterial blood gases are analyzed. The infant is placed in a warm incubator with a gentle and minimal handling to conserve energy. Oxygen toxicity is a high risk for infants receiving prolonged treatment with high concentrations of oxygen. Bronchopulmonary dysplasia is the toxic response of the lung to oxygen therapy. This often results in prolonged dependence on supplemental oxygen and ventilators and has long-term complications. Apnea is defined as the cessation of breathing for 20 seconds or longer. It is not uncommon in the preterm newborn, and it is believed to be related to immaturity of the nervous system. An apneic episode may be accompanied by bradycardia and cyanosis. Gentle rubbing of the infant's feet, ankles, and back can stimulate breathing after this occurrence. If breathing does not begin, an ambu bag is used. Neonatal hypoxia is an inadequate oxygenation at the cellular level in a newborn infant. The degree of hypoxemia present may be detected by a non-invasive pulse oximetry reading. A pulse oximeter saturation level of 92% or higher is normal. If the hemoglobin present is an abnormal fetal hemoglobin, hypoxia can be present even when the pulse oximeter shows a normal reading, because fetal hemoglobin does not readily release oxygen to the tissues and end organs. Sepsis is a generalized infection of the bloodstream. Preterm newborns are at risk for developing this complication because of immaturity of many body systems. There may be no local signs of infection, which also hinders a diagnosis. Some signs of sepsis include a low temperature, lethargy or irritability, poor feeding, and respiratory distress. Treatment involves administration of IV antimicrobials, maintenance of warmth and nutrition, and close monitoring of vital signs, including blood pressure. Heat loss in the preterm infant results from the following factors. The preterm infant has a lack of brown fat, which is the body's insulation. There is excessive heat loss by radiation from a surface area that is large in proportion to body weight. The heat-regulating center of the brain is immature. The sweat glands are not functioning to capacity. The preterm infant is inactive, has muscles that are weak and are less resistant to cold, and they cannot shiver. The posture of the preterm infant's extremities is at one of leg extension. Metabolism is high, and the preterm infant is prone to low blood glucose levels. The infant's skin temperature will decrease before the core temperature falls. Therefore, a skin probe is used to monitor the temperature of preterm infants. Hypoglycemia is common among preterm infants. Any condition that increases energy requirements will place more stress on the already deficient stores. Plasma glucose levels lower than 40 milligrams per deciliter in a term infant and lower than 30 milligrams per deciliter in a preterm infant can indicate hypoglycemia. Nursing responsibilities include frequent glucose monitoring and nasogastric or parenteral feedings. Hypocalcemia is also seen in preterm and sick newborns. Infants stressed by hypoxia or birth trauma or who are also receiving sodium bicarbonate are at a high risk for this problem. Infants born to mothers who are diabetic or who have had a low vitamin D intake are also at risk for developing early hypocalcemia. Administering intravenous calcium gluconate is the treatment for hypocalcemia. During intravenous therapy, the nurse should monitor the infant for bradycardia. Preterm infants are more prone to bleeding than full-term infants because their blood is deficient in prothrombin, a factor of clotting mechanism. The nurse should monitor the neurological status of the infant and report any bulging fontanelles, lethargy, poor feeding, and seizures. Retinopathy of prematurity is a disorder of the developing retina in premature infants that can lead to blindness. After birth, often accompanied by high levels of oxygen required for the infant's survival, the retina completes an abnormal vascularization process that causes fibrous tissue to form behind the lens of each eye, resulting in blindness and retinal detachment. The stomach capacity of the preterm infant is small. Parental or oro-gavage feedings are usually required until the infant is strong enough to tolerate oral feedings without compromising cardiorespiratory status. Necrotizing enterocolitis is an acute inflammation of the bowel that leads to bowel necrosis. Preterm newborns are particularly susceptible to NEC. Signs of NEC include abdominal distension, bloody stools, diarrhea, and bilious vomitus. Specific nursing responsibilities include observing vital signs, maintaining infection control techniques, and carefully resuming oral fluids as ordered. Treatment includes antimicrobials and the use of parenteral nutrition to rest the bowels. Surgical removal of the necrosed bowel may be indicated. Improper elimination of body waste contributes to electrolyte imbalance and disturbed acid-base relationships. Dehydration occurs easily, and the tolerance to salt is limited. Susceptibility to edema is increased. The urine output should be between 1 and 3 milliliters per kilogram per hour. The infant should be observed closely for signs of dehydration or overhydration. Thermoregulation involves maintaining a stable body temperature and preventing hypothermia and hyperthermia. Nurses must understand how to use incubators available in the nurseries to which they are assigned. The temperature of the incubator is adjusted to a level that will maintain an optimal body temperature in the infant. The nurse records the temperature of the infant and the incubator every 2 hours. The infant's temperature is monitored with a heat-sensitive probe that is taped to the abdomen. Radiant heat cribs that supply overhead heat have the advantage of providing easier access to the patient while maintaining a neutral thermal environment. Kangaroo care is a method for preterm infants that uses skin-to-skin contact. The infant, wearing only a diaper and small cap, will rest on the mother's or father's naked chest. The skin provides warmth and calms the child, and the contact promotes bonding. The ability to coordinate breathing, sucking, and swallowing does not develop before 34 weeks gestation. Infants weighing more than 3.3 pounds may be able to bottle feed if a small, soft nipple with a large hole is used to minimize the energy and effort required for sucking. Human milk is ideal because the fat is absorbed readily. Often the infants are fed while still in the incubator. Early initiation of feedings will reduce the risk of hypoglycemia, hyperbilirubinemia, and dehydration. The nurse should observe and record bowel sounds and the passage of meconium, indicating that intestinal readiness for oral feedings has occurred. When the infant is gavage fed, the contents of the stomach should be aspirated before the feeding is started. Supplemental vitamins are typically prescribed for the preterm infant. The experienced nurse in the preterm nursery will observe charts, care, and treatment in great detail. In the NICU environment with close observation, the preterm newborn can be positioned on the side or prone, with the head of the mattress slightly elevated unless contraindicated. Positioning of the preterm infant should be compatible with the drainage of secretions and prevention of aspiration. Infants should be gradually weaned from the prone position when the physical condition becomes stable, and they should be placed in the supine position well before discharge from the NICU. The infant should not be left alone in one position for long periods because it is uncomfortable and may harm the lungs. Daily cleansing of the eyes, mouth, and diaper area, and baths 2 to 3 times weekly with the application of emollients like Eucerin or Aquaphor can promote skin integrity. Every effort should be made to maintain a quiet environment and organize nursing care so that overstimulation of the preterm infant is avoided. The preterm infant should be awakened slowly and gently for procedures or nursing care and should be moved gently, maintaining flexion of the arms close to the midline of the infant's body. In general, growth and development of the preterm infant are based on current age minus the number of weeks before term that the infant was born. The nurse should assist the parents to cope with their responses to having a small preterm infant. They should touch and immediate human contact. These are vital for the infant. Nursing care of the preterm infant includes measures to provide short periods of stimulation during the alert phase of activity. The parents can be taught to provide stimulation by using a black and white mobile, stroking gently, talking to the infant, rocking, or providing range of motion activity or kangaroo care. Care should be taken not to overly stimulate or tire the infant. Often a mother is just discharged without her infant. This is difficult for the entire family and makes attachment and bonding more complicated. The newborn is considered post-term if the pregnancy goes beyond 42 weeks. Identification of infants who are not tolerating the extra time in the uterus is a major goal of treatment. Morbidity rates are also higher. After the infant survives delivery, the risks are fewer. The late birth is a psychological strain on the mother, the father, and other members of the family who are eagerly awaiting the arrival of the new child. The following problems are associated with post-maturity: asphyxia, meconium aspiration, poor nutritional status, increase in red blood cell production, difficult delivery due to the increased size of the infant, birth defects, or seizures. The post-term infant is long and thin and looks as though weight has been lost. There is little lanugo or vernix caseosa. The loss of that cheese-like vernix caseosa leaves the skin dry. It will crack, peel, and is almost like parchment in texture. The infant has a thick head of hair and looks alert. Labor induction or cesarean deliveries are commonly performed if testing determines that the pregnancy is past 42 weeks, or if there are signs of fetal distress or maternal risk. Nursing care involves observing for respiratory distress, hypoglycemia, and hyperbilirubinemia. Transportation of the high-risk newborn to a regional neonatal center requires the organization and expertise of a special team. Stabilization of the infant before discharge is important. Copies of all records are made, including the infant's record, the mother's prenatal history and delivery, and pertinent admission data. A transport incubator is provided for warmth, and the batteries are kept fully charged. The nurse is responsible for placing an identification band on the infant before transport and for verifying the identification name and number with the mother's ID band. The parent should be given the name and location of the receiving hospital and the name and telephone number of a physician to contact for follow-up information and visits. Parents should be shown the newborn before departure. Discharge planning will begin at birth. The nurse stresses the importance of well baby examinations, immunizations, and prevention of infection. Parents are often anxious about taking their high-risk newborn home. The nurse must familiarize them with the newborn's care. Support group referrals are given to parents, and newborn cardiopulmonary resuscitation techniques are reviewed. Birth defects are abnormalities that are apparent at birth, and they occur in 3 to 4% of all live births. An abnormality of structure, function, or metabolism may result in a physical or mental disability, may shorten life, or may be fatal. Defects present at birth often involve the skeletal system. Limbs may be missing, malformed, or duplicated. Inborn errors of metabolism include a number of inherited diseases that affect body chemistry. In disorders of the blood, there is a reduced or missing blood component or an inability of the component to function adequately. Congenital malformations are those defects present at birth. Neural tube defects are most often caused by a failure of neural tube closure at either the cranial or the caudal lower end of the spinal cord. These defects often result in hydrocephalus and spina bifida. Hydrocephalus in the newborn is a condition characterized by an increase of CSF within the ventricles of the brain. This causes pressure changes in the brain and an increase in head size. It results from an imbalance between the production and absorption of CSF or improper formation of the ventricles. Hydrocephalus may be congenital or acquired. The symptoms depend on the site of obstruction and the age at which it develops. Hydrocephalus is classified as non-communicating or communicating. The signs and symptoms of hydrocephalus depend on the time of onset and the severity of imbalance. The classic sign is an increase in head size. The scalp is shiny and the veins are dilated. The body becomes thin and the muscle tone of the extremities is often poor. The cry is shrill and high-pitched. Irritability, vomiting, and anorexia are present, and convulsions may occur. Transillumination is the inspection of a cavity or organ by passing a light through its walls. This is a simple diagnostic procedure that is useful in visualizing fluid. A flashlight with a sponge rubber collar is held tightly against the infant's head in a dark room. The examiner observes for areas of increased luminosity. A small ring of light is normal, but a large halo effect is not. A ventricular tap or puncture may be performed using a sterile technique to determine the pressure and drain CSF. The use of acetylzolamide and furosemide will reduce the production of CSF and may provide some relief, but often surgery is indicated. The surgeon will attempt to bypass or shunt the point of obstruction. This procedure is known as a ventriculoperitoneal shunt. It allows the excess fluid to drain into the peritoneal cavity, where it can be absorbed. If the brain is not seriously damaged before the operation, mental function can be preserved. Complications of shunts are usually mechanical or infections. Most often, surgical correction can be accomplished in utero via fetal surgery or shortly after birth to prevent brain damage caused by increased intracranial pressure. The immediate preoperative care is routine, involving assessment of vital signs and skin preparation, and emotional support of the parents. The position of the infant must be changed frequently to prevent hypostatic pneumonia and pressure sores. When the nurse turns an infant who has hydrocephalus, the head must always be supported. When the infant is lifted from the crib, the head must be supported by the nurse's arm and chest. In most cases, the nurse can hold the infant for feedings. The infant should not be disturbed once settled because vomiting occurs easily. Observations to be recorded and reported include the type and amounts of food taken, any vomiting, the condition of the skin, motor abilities, restlessness, irritability, and a change in vital signs. Symptoms of increased intracranial pressure within the head are an increase in blood pressure and a decrease in pulse rate and respirations. In addition to routine postoperative care and observations, the nurse observes the patient for signs of increased intracranial pressure and of infection at the operative site. or along the shunt line. As with any postoperative care, pain control management is essential. The infant is always positioned in a way that prevents pressure on the operative site. The infant should be observed for signs of increased ICP. The development of a high-pitched cry, unequal pupil size, or response to light, bulging fontanelles, irritability or lethargy, poor feeding, or abnormal vital signs should be reported and recorded. The surgical suture line should be kept clean and dry, and the infant's diaper kept well below the abdominal suture line to prevent contamination. Parent education, support, and guidance are essential. Spina bifida, also known as myelodysplasia, refers to a group of central nervous system disorders characterized by malformation of the spinal cord. Spina bifida is a congenital embryonic neural tube defect in which there is an imperfect closure of the spinal vertebrae. There are two forms, occulta and cystica. There may be a tuft of hair, dimple, lipoma, or discoloration at the site. These symptoms will consist of progressive disturbances of gait, such as foot drop, or disturbances of bowel and bladder sphincter function. Hydrocephalus is a common complication. The use of drugs during early pregnancy and poor nutrition can contribute to the development of a neural tube defect. Studies have shown that the intake of folic acid before conception dramatically reduces the occurrence of neural tube defects, such as spina bifida. The treatment for spina bifida is a surgical closure. The prognosis for patients with these conditions will depend on the extent of involvement. Habilitation rather than rehabilitation is the term used to describe this treatment. This is necessary after the operation because the legs will remain paralyzed and the patient is incontinent of urine and feces. Because the patient is disabled from birth and therefore they will be learning rather than relearning. The aim of habilitation is to minimize the child's disability and put to constructive use the ineffective parts of the body. Eventually, the child can be taught to use a wheelchair and possibly to walk with braces, crutches, or other walking devices. The main objectives of nursing care include prevention of infection or injury to the sac, correct positioning to prevent pressure on the sac, and the development of contractures, as well as good skin care. Adequate nutrition, accurate observations and charting, education of the parents, continued medical supervision, and habilitation. Moist, sterile dressings of saline or an antibiotic solution can be ordered to prevent drying of the sac. Some method of protecting the mass is necessary if surgery is to be delayed. Along with other routine observations made for every newborn, other pertinent nursing observations must be made and recorded, including the size of the sac. The extremities should be observed for any deformities and movement. Head circumference should be measured. Fontanelles are observed. The lack of anal sphincter control and dribbling of urine are also significant in differential diagnosis. Positioning of the infant is important. The goal is to prevent pressure on the sac and avoid postural deformities. Postoperative nursing care involves neurological assessment and the prevention of infection. Complications that can be life-threatening include meningitis, pneumonia, and UTI. Urological monitoring is essential because many of these infants will have urinary incontinence. Constant dribbling of feces and urine irritates the perineal area and can affect the sac or incision, so meticulous cleanliness is necessary. Constant feeding will be facilitated by early closure of the defect. In delayed cases, gavage may be used. These patients will need cuddling and sensory stimulation. Many infants with spina bifida develop a latex allergy. A latex-free environment should be adopted whenever possible. Special consideration should be given to the establishment of the parent-infant relationships. A cleft lip is characterized by a fissure or an opening in the upper lip. It is a result of the failure of the maxillary and median nasal processes to unite during embryonic development, usually between the 7th and 8th weeks of gestation. This disorder appears more frequently in boys than in girls and may occur on one or both sides of the lip. Sometimes it is accompanied by a cleft palate, a fissure in the midline of the roof of the mouth. The initial treatment for cleft lip is surgical repair known as cheiloplasty. The cleft lip is repaired before 6 months of age when weight gain is established and the infant is free of infection. The physician may order elbow restraints to prevent the infant from scratching the lip and to acquaint the infant with them because they may be necessary postoperatively. Postoperative nursing goals for the infant undergoing a cheiloplasty include the following: preventing the infant from sucking and crying, careful positioning, preventing infection and scarring, preventing injury to the operative site with the use of elbow restraints, providing for the infant's emotional needs by cuddling, and providing appropriate pain relief and sedation. The infant will receive feedings by dropper until the wound is completely healed. Sucking is prevented as much as possible until the suture line is healed. Holding the infant during feedings, burping frequently, and placing the infant in an infant seat after feeding or on the right side propped with a rolled blanket will aid in a positive outcome for the infant. A cleft palate is the failure of the hard palate to fuse at the midline during the 7th to 12th weeks of gestation. This separation forms a passageway between the nasopharynx and the nose, which not only complicates feeding, but also easily leads to infections of the respiratory tract and middle ear that could result in hearing loss. Feeding is a problem because the cleft prevents negative pressure from being formed within the mouth, which is necessary for successful sucking. The goals of therapy are union of the cleft, improved feeding, improved speech, improved dental development, and the nurturing of a positive self-image. Treatment of the child with a cleft lip and palate will require multidisciplinary teamwork. A mother's first reaction to a disfigured newborn is one of shock, hurt, disappointment, and guilt. The parent and family need understanding, a concrete basis for hope, and practical advice. The parents are instructed about the resources available in the state in which they live. Fluids are taken by cup, although gravity feeders can be used in some cases. The patient must not suck on a straw. The spoon should not touch the roof of the mouth. Elbow restraints will be used to prevent the child from placing his or her fingers or objects in the mouth. The mouth is kept clean at all times. Feedings are followed by a little water. It is helpful to speak slowly and distinctly to the child. The speech therapist will evaluate the child and assist the parents in specific activities that facilitate speech development. Crying is to be prevented as much as possible. Ear infections and dental decay may accompany a cleft palate. Clubfoot, one of the most common deformities of the skeletal system, is a congenital anomaly characterized by a foot that has been twisted inward or outward. Many mild forms are caused by improper position in the uterus, and these clear up with manipulative exercises. The feet are turned inward, and the child walks on the toes and outer borders of the feet. It generally involves both feet. The treatment of clubfoot is started as early as possible, or the bones and muscles will continue to develop abnormally. If these methods are not effective by age 3 months, surgery may be indicated. Casts will be made of plaster or synthetic materials, such as fiberglass or polyurethane. Indentations made in a wet cast by fingers can press on the underlying skin and cause damage. The toes should be left exposed for observation. The nurse will check them for capillary refill and signs of poor circulation, pallor, cyanosis, swelling, coldness, numbness, pain, or burning. As the infant grows, the cast may need to be removed and reapplied. Because the infant grows rapidly, parents should be taught how to check for circulation impairments, which could be caused by a tight cast. If a discolored area appears on the cast, it is circled and the time is recorded. Education concerning the therapy and referral for follow-up care is an important nursing responsibility. Developmental hip dysplasia, formerly known as congenital hip dysplasia, is a common orthopedic deformity. The head of the femur is partly or completely displaced as a result of shallow hip socket. Hereditary and environmental factors appear to be causal factors. Early detection and treatment are of particular importance, so that treatment can be started before ossification occurs. A dislocation of the hip is commonly discovered at the periodic health examination of the infant during the 1st or 2nd month of life. One of the most reliable signs is a limited abduction of the leg on the affected side. A healthcare provider will perform an Ortolani or a Barlow test to detect an unstable hip in the newborn. In infants with developmental dislocation of the hip, the physician can actually feel and hear the femoral head slip back into the acetabulum under gentle pressure. This is known as Ortolani sign. Radiographic studies will confirm this diagnosis. Treatment begins immediately on detection of the dislocation. The hips are maintained in constant flexion and abduction for 4 to 8 weeks to keep the head of the femur within the hip socket. Long-term immobilization with a Pavlik harness may be required. Traction may be necessary if the dislocation is severe or is not detected until the child begins to walk. Casting in a frog-like position is then done. The length of time spent in the cast will vary according to the patient's progress and growth and the condition of the cast. However, it is usually several months. Surgery may be required in infants more than 18 months of age who do not respond to treatment. The nursery nurse will carefully observe each infant during the bath to detect any signs of hip dysplasia. When the infant is prone, the nurse should observe the buttocks for variation in size. The legs of the infant should be equal in length. The infant should be kicking both legs, not just one leg. And the depth and number of skin folds of the infant's upper thighs should be symmetrical. Firm, plastic covered pillows are required when the patient has a spica cast. These are typically placed beneath the curvature of the cast for support. The head of the patient's bed should be slightly elevated so that urine or feces will drain away from the body of the cast. Frequent changes of position are important. Immobilized patients must be turned often. The supporting bar between the legs should never be used as a lever when turning the child. Itching is a problem for the patient in a body cast. Toys small enough to be hidden inside the cast should never be given to the child. As the infant adjusts to the birth process and begins to ingest nourishment, symptoms could rapidly emerge that quickly become life-threatening. Symptoms such as lethargy, poor feeding, hypotonia, a unique odor to the body or urine, tachypnea, and vomiting must be reported by the nurse in the newborn nursery to prevent long-term or life-threatening sequelae. Classic fetal ketonuria is a genetic disorder caused by the faulty metabolism of phenylalanine, an amino acid that is essential to life and found in all protein foods. This inborn error of metabolism, which is transmitted by an autosomal recessive gene, is termed classic PKU and is associated with a blood phenylalanine level of above 20 milligrams per deciliter. Classic PKU results in severe retardation that is evidenced in infancy. Early detection and treatment are paramount. By the time the urine test is positive, brain damage has already occurred. The infant appears normal at birth, but begins to show delayed development at about 4 to 6 months of age. The child may show evidence of failure to thrive, have eczema or other skin conditions, have a peculiar, musty odor, or have personality disorders. The Guthrie blood test is used widely to detect PKU and is currently considered the most reliable test for the disorder. Confirmation of the diagnosis will require quantitative elevations of phenylalanine compound in the blood. Treatment of PKU consists of close dietary management and frequent evaluation of blood phenylalanine levels. The most commonly used formulas are Lofenalac or Phenex-1 for infants, Phenol-free for children, and Phenex-2 for adolescents. The goals of the diet are to provide enough essential proteins to support the growth and development while maintaining phenylalanine blood levels between 2 and 10 milligrams per deciliter. There is a low phenylalanine content in breast milk. A dietitian can be consulted regarding parental guidance and support in maintaining the dietary regimen, especially for the school-age child and adolescent. Genetic counseling is important for the affected child for future family planning. Down syndrome is one of the most common chromosomal abnormalities. It is the most common cause of genetic intellectual disability, and children born with this birth defect may also have some physical abnormalities. There are three phenotypes of Down syndrome: trisomy 21, mosaicism, and translocation of a chromosome. Screening for Down syndrome is offered during the first trimester of pregnancy and includes an ultrasound assessment of the thickness of the fetal nuchal fold and the absence of the nasal bone. A second trimester quad test involves testing of the blood for levels of AFP, unconjugated estriol, inhibin A, and human chorionic gonadotropin. Positive tests in the first or second trimester may indicate the need for an amniocentesis to confirm the diagnosis. Down syndrome can be diagnosed by the clinical manifestations, but a chromosomal analysis will confirm the specific type. The signs of Down syndrome, which are apparent at birth, are close-set and upward slanting eyes, small head, round face, flat nose, protruding tongue that interferes with sucking, and mouth breathing. Physical growth and development may be slower than normal. Congenital heart deformities are also associated with this condition. Their resistance to infection is poor, and they are more prone to respiratory and ear infections, in addition to speech and hearing problems. The limp, flaccid posture of the infant is caused by hypotonicity of the muscles. It makes positioning and holding more difficult and contributes to heat loss from the exposed surface areas. The counseling of families with Down syndrome children is ongoing. The nurse must listen and provide honest, tactful, and compassionate support. Empathy from the nurse is particularly important. Siblings of the patient must be informed and included in discussions about the newborn. Early and open communication will prevent isolation and misconceptions and promote an easier transition period. The nurse should connect the family with Down syndrome to a support group in their area if there is one. Erythroblastosis fetalis is a disorder that becomes apparent during fetal life or soon after birth. It is one of many congenital hemolytic diseases found in the newborn. It is caused when an Rh-negative mother and an Rh-positive father produce an Rh-positive fetus. If large numbers of antibodies are present, the infant may be severely anemic. In the gravest form, the progressive hemolysis causes anemia, fetal hypoxia, anasarca, and heart failure. An extensive maternal health history is obtained. Of particular interest are previous Rh sensitizations, an ectopic pregnancy, abortion, blood transfusions, or children who develop jaundice or anemia during the neonatal period. Diagnosis of the disease in the prenatal period is confirmed by amniocentesis and monitoring of bilirubin levels in the amniotic fluid. Prevention of erythroblastosis is by the use of RhoGAM, immune globulin. This is now routine. An intramuscular injection is given to the mother within 72 hours of delivery of an Rh-positive infant. The direct Coombs test detects damaging antibodies. The symptoms of erythroblastosis fetalis will vary with the intensity of the disease, but anemia and jaundice are typically present. Enlargement of the liver and spleen are extensive, and edema may develop. The oxygen-carrying power of the blood is diminished, as is the blood volume, and therefore shock or heart failure can occur. Treatment includes the prompt identification, lab test, drug therapy after birth, phototherapy, and exchange transfusion if indicated. For the infant after birth, the hemoglobin level and degree of hyperbilirubinemia will determine if exchange transfusion is necessary via the umbilical vein. Administration of IV immunoglobulin at birth can reduce red blood cell destruction in the newborn, thereby reducing hyperbilirubinemia and the need for exchange transfusion. Phototherapy will be contraindicated in infants with a history of congenital polyphyra or the use of photosensitizing drugs. The nurse is usually responsible for the following: observing the newborn's color and reporting any evidence of jaundice during the first or second days, stressing to mothers the importance of good prenatal care for subsequent pregnancies, helping to interpret the treatment to parents by giving reassurance as needed and observing and assisting the physician with the exchange transfusion. Home phototherapy programs are being used for newborns with mild to moderate physiological jaundice. Home therapy is less costly. A phototherapy blanket and a bassinet or a fiber optic pad can be used. Intracranial hemorrhage, the most common type of birth injury, can result from trauma or anoxia. It occurs more often in the preterm infant whose blood vessels are fragile. When the diagnosis is made, the specific location of the hemorrhage may be noted. Some signs or all signs can be present depending on the severity of the hemorrhage and can include poor muscle tone, lethargy, poor sucking reflex, respiratory distress, cyanosis, twitching, forceful vomiting, a high-pitched shrill cry, and convulsions. If the symptoms are mild, most patients have a good chance of complete recovery. Death results if there is a massive hemorrhage. The diagnosis is established by the history of delivery, CT scan, MRI, evidence of an increase in ICP, and the symptoms as well as the course of the disease. The newborn is placed in an incubator, which allows for the proper temperature control, ease in administering oxygen, and continuous observation. The infant is handled gently and as little as possible. The head is elevated. The nurse observes the infant for signs of increased ICP and convulsions and assists the physician with procedures such as lumbar punctures and aspiration of subdural hemorrhage. Performing neurochecks, monitoring vital signs and head circumference, and palpating fontanelles is essential. Transient tachypnea of the newborn usually occurs after a cesarean section birth or a rapid vaginal delivery of a term infant. It is characterized by tachypnea and may also include chest retractions, grunting, or mild cyanosis. TTN is thought to be caused by slow absorption of the fluid in the lungs after birth. Treatment is supportive, providing warmth, energy conservation, and supplemental oxygen. Meconium aspiration syndrome is a group of symptoms that occur when the fetus or newborn aspirates meconium-stained amniotic fluid in the lungs. In utero, the fetus often expels some meconium into the amniotic fluid during a prolonged labor process, especially if there is cord compression or another condition that temporarily interrupts fetal circulation. If asphyxia and acidosis occur in utero, the fetus may make gasping movements that draw meconium-stained amniotic fluid into the lungs. This condition can also occur when the infant takes his or her first breath before the nose and mouth are suctioned, and meconium-stained amniotic fluid in the upper airway passages is drawn into the lungs. Meconium aspiration can be prevented by promoting identification of fetal distress and rapid delivery when the fetal heart tracings show decelerations and loss of variability. Respiratory distress is the primary symptom of MAS, including nasal flaring, retractions, cyanosis, grunting, rales, and rhonchi. Treatment includes supportive care with warmth, supplemental oxygen, and energy-conserving plans of care. Neonatal abstinence syndrome occurs when the fetus has prenatal exposure to drugs like opiates, amphetamines, tranquilizers, or multiple illicit drugs while in utero. Because these drugs cross the placenta, the infant born to an addicted mother is physiologically dependent on the drugs and will suffer withdrawal symptoms after birth, in addition to possibly long-term developmental and neurological deficits. Body tremors and hyperirritability are the principal signs of this condition in the newborn. Treatment includes providing a quiet environment with swaddling, reduction of external stimuli, and the close observation for seizures. Many newborn infants of diabetic mothers have serious complications. When the mother is hyperglycemic, large amounts of glucose are transferred to the fetus. This makes the fetus hyperglycemic. Hyperinsulinism, along with the excess production of fatty acids and protein, will often result in a newborn infant who weighs more than 9 pounds. Such an infant is designated as large for gestational age, and this condition is termed macrosomia. The infant has a characteristic Cushingoid appearance due to the increased subcutaneous fat. The face is round and appears puffy, and the infant appears lethargic. The nursing care of the infant of a diabetic mother includes close monitoring of vital signs, early feeding, and frequent assessment of blood glucose levels for the first 2 days of life. The infant should be closely watched for signs of irritability, tremors, or respiratory distress.